Okay, it's just gone past 4 and we've got 54 people in attendance. So we're going to start. Today's talk is CML, Morphology, Metaphases, Mutations, Medication, and Measurability by Prof. Adam Bagg, and Prof. Jessica O.P. will be chairing. And it's brought to you by Blood Assay and UCT in strategic partnership with SAGAS and SASETS. And by now you know the three of us very well, myself, Nicola Smith, Prof. Berg, and Dr. Kritzinger, Khadin. And all our sessions are recorded and can be found on the website under Resources and Deep Dive. Please feel free to add any questions to the chat and they'll be attended at the end of the session. CPD points will be submitted for each registered South African attendee. Please make sure you're using your own Zoom link and not in a group. Attend for at least an hour and please make sure your number is entered correctly when you sign up for Deep Dive. For any queries, you can just email us at admin@bloodassay.org.za. Our mailing list, you can either scan the QR code now or you can go to our website, Resources, subscribe to Deep Dive. And we really value your feedback. So at the end, please wait the 2 or 3 seconds it takes for the form to come up and then complete the anonymous feedback survey. That helps our speakers know what works, what doesn't work, and what do you enjoy most. So the structure of the session, we'll have a talk by Prof. Bagg, and then Q&A, and closing will be around 5:15, 5:30, depending. And then over to Jessica.
It's my great pleasure to welcome Prof. Adam Bagg again to this Deep Dive Forum. He is very generous with his time. He recently gave 2 excellent lectures at PathRed, and we're now delighted to have you back, Adam, to speak about CML. So I think most people know you very well, but for those who don't, you are going to be in for a treat. Prof. Bagg graduated from Wits some time ago, and he's now an emeritus professor of pathology at the University of Pennsylvania. He's won numerous awards. He's been voted by his peers as Philadelphia's top doctor, and he has lectured extensively both in the US and internationally in over 20 countries and has over 260 publications. And he is an exceptional photographer. He travels. He has a huge thirst for travel and culture and music. So an extremely knowledgeable and wonderful person to have speaking here. And we're looking forward very much. Thank you very much, Adam.
Thanks very much, Jessica, for the introduction. Let me make sure that I share my screen. Click there, click there. So you should be able to see my black square in the middle of the screen. Is that visible to all?
Yes.
That's visible. Thank you.
Okay, I'm going to switch off my video and go into that mode and ready to rock and roll. So thank you very much again. As you mentioned, the title of my talk is Chronic Myeloid Leukemia with a subtitle of Morphology, Metaphases, Molecular Medication, and Measurability. Probably not necessary for this audience, but in case there are any budding high schoolers listening in or watching, just a very superficial overview of how we classify myeloid neoplasms into those that are acute and those that are chronic. The acute ones more likely to be lethal in the short term, and that, of course, in the myeloid realm is acute myeloid leukemia. But there are a whole spectrum of different chronic myeloid neoplasms. At one end, the myeloproliferative neoplasms, MPN, at the other, the myelodysplastic syndromes. A more recent characterized and classified overlap syndromes encompassing myeloproliferatives and myelodysplastic syndromes, systemic mastocytosis, and myeloid and lymphoid neoplasms with tyrosine kinase gene fusions. Sometimes, at least when registrars are beginning their journey into hematopathology, they may struggle with sort of understanding the differences between a myeloproliferative and a myelodysplastic neoplasm or syndrome. I think it's useful to think of both of these as neoplastic hematopoietic stem cell disorders, that when you do a bone marrow aspirate biopsy on them, you will see quantitatively increased hematopoiesis, a very hypercellular marrow for age. But the differences are as to whether the quantitatively increased hematopoiesis is effective or ineffective. And if it's effective, there will be high peripheral counts typically, and that's generally what typifies the myeloproliferative neoplasms. By contrast, if this quantitatively increased hematopoiesis is functionally ineffective, often allied to increased apoptosis in the bone marrow, there will be low peripheral counts, and that's what typifies the myelodysplastic syndromes. Of course, another important facet may be a clinical feature. Often there is extramedullary hematopoiesis in MPNs, less common in MDS. So the presence of splenomegaly may be another clue that can help push you in one direction or another if you're struggling based upon the hematologic and pathologic features. There are a number of different types of myeloproliferative or indeed chronic myeloid neoplasms, as I alluded to. With regard to the MPMs, they're the classic forms, CML versus the pH negative ones. The pH negative ones encompass, of course, polycythemia vera, essential thrombocythemia, and primary myelofibrosis. The more recently added non-classical forms include chronic eosinophilic leukemia, chronic neutrophilic leukemia, and an unclassifiable category. The overlap forms include CMML, JMML, atypical CML, unclassifiable, and what was formerly called RST is now referred to TSF3B1 to align with the molecular classification of MDS with ring sideroblasts. Of course, there's this previous mouthful of an entity of myeloid and lymphoid neoplasms with eosinophilia and rearrangements of platelet-derived growth factor receptor alpha, platelet-derived growth factor receptor beta, fibroblast growth factor receptor 1, and PCM1 JAK2 fusions with the 4 members of the club listed here. That's been expanded and simplified over the years to these 6 categories, and it was something I was fortunate enough to cover to a couple of months ago in this forum. I will try every now and again to sort of highlight some differences between the ICC and WHO classifications of 2022, although these are likely to be aligned and unified with some sort of détente emerging between these 2 groups, and a new classification scheme slated for 2027. So look out for that. But in the interim, WHO has moved JMML out of the blended MPN MDS category into a pure myeloproliferative neoplasm, for what that's worth. Focusing now on the classical myeloproliferative neoplasms, the facets they have in common: they are true stem cell disorders, as I've mentioned. Unlike acute leukemias, they are not characterized, at least in their chronic phase, by maturation arrest. Rather, they're characterized by accumulating numbers of cells due to not only increased proliferation but decreased death of the cells, with the cells morphologically being mature hematopoietic cells, mature and maturing cells without an expansion or a substantial expansion of blasts. And although we name them according to the lineage that is increased in P. vera, it's red cells, you can have a leukocytosis in P. vera. You may have a thrombocytosis in CML, and so on and so forth. So they may not be restricted to the lineage after which they are named. As mentioned, splenomegaly is quite common as a consequence of extramedullary hematopoiesis. In the peripheral blood, basophilia, increased numbers of basophils, is a feature. And they have a variable proclivity to transform into an acute leukemia. So here is a classic peripheral blood smear of a patient with CML. Looks like myelopoiesis has spilt over into the blood. There are all phases of maturation, an interesting myelocyte bulge to contrast it with toxic, secondary leukemoid reactions. Similarly, there's no toxic granulation or Dolly bodies that you may see in a secondary leukemoid reaction, and of course, basophilia. And up to 1/2 of patients with CML are asymptomatic, and they are diagnosed on a routine medical and routine blood counts. So chronic myeloid leukemia, then summarizing the features you would look for in the peripheral blood: granulocytes, myeloid maturation in all phases, increased numbers of blasts are allowed, indeed up to 10% before you may consider metamorphosis or progression of the disease, and then characteristic increased numbers of basophils. And although it's really the peripheral blood morphology that alerts us to a diagnosis of chronic myeloid leukemia, there are some features in the bone marrow as well. So as illustrated here is a very packed bone marrow biopsy, markedly hypercellular, but lurking in the background, if you look closely and now circled, you can see the characteristic small hypolobated megakaryocytes. These can, of course, also be seen and are often easily seen by an astute observer in the bone marrow aspirate smear, and I have that illustrated here. People have asked me what are the reasons for the sort of divergence of the ICC and the WHO, and certainly there were scientific reasons, there were political reasons, there were personal reasons, and this sort of delayed the publication of these classification schemes. But another one that most people didn't know about was actually financial. It was a lack of a sponsor to publish these tomes. But fortunately, they found a sponsor, but that came at a bit of a price. The sponsor was Walt Disney. So now the dwarf, so-called dwarf or little people megakaryocytes, have to be distinguished from one another with 7 broad flavors of dwarf megakaryocytes that a hematopathologist is required to recognize, distinguishing sleepy from grumpy, from dopey, from bashful, from sneezy, from doc, and of course, happy dwarf megakaryocytes. Another feature you may see in these 2 images that unfortunately are not of the same magnification, but I hope it makes the point that in a typical bone marrow, you may see in a cuff juxtaposed to the bony trabeculum some increased immature myeloid cells, and that accounts for 2 to 3 cells in a normal bone marrow on the left-hand side. By contrast, the very classic features, but it's not something we're going to use for diagnosis, but again, worth looking out for, is an expanded paratrabecular cuff in CML, sometimes between 5 and 10 immature left-shifted cells seen, in contrast to what you may see in a normal bone marrow. Another clue to, or interesting feature of the CML bone marrow core biopsy are cells that resemble those seen in Gaucher's disease. So in chronic myeloid leukemia, as a consequence of the rapid cell turnover and death, macrophages are working overtime and they develop morphologic features resembling those seen in Gaucher's disease, and they are referred to as pseudo-Gaucher cells. Somewhat similar, but certainly not identical cells can be seen in another very interesting hematologic disorder, often associated with insoluble light chains in myeloma or chronic B-cell neoplasm, so-called crystal storage histiocytosis, in which the jam-packed macrophages or histiocytes are referred to as pseudo-Gaucher cells. The Philadelphia story is worth recapitulating here. I'm not referring to the classical American movie made in 1940 starring Cary Grant, Katharine Hepburn, and James Stewart, but rather a Philadelphia story that began in the city of Philadelphia in 1960, 20 years after the release of that movie. This is a more recent picture of Philadelphia from the university. Wouldn't have looked like this in 1960, but along came a very sharp cytogeneticist, Peter Knoll, who together with David Hungerford, and for the first time on chromosomal studies, illustrated an abnormality in what was then called CGL, chronic granulocytic leukemia, in which there was a shortened chromosome 22. And that was the so-called Philadelphia chromosome, so named by others. It took another 13 years, through 1973 now, when Janet Rowley in Chicago, with more robust and better heme sustaining technology, was able to demonstrate that the short chromosome 22 was as a consequence of a balanced translocation between chromosomes 9 and 22. And some people state, perhaps a little bit ungenerously, what was lost in Philadelphia was found in Chicago. About 13 years after that, 1986 roughly now, Grossman, Kanani, Stivelman, and others cloned the genes involved in this translocation, the BCR and Abelson genes. And 13 years after that, we're in 1999, roughly, at the turn of this century, when Brian Drucker and colleagues developed STI-571, which we now know as Gleevec or imatinib, which is a very magical inhibitor of the BCR-ABL kinase and has transformed the natural history of this disease. I was fortunate in my early days in Philadelphia, roughly 25 years ago, to co-author a review article with the late great Peter Knoll, who really was a wonderful man. At this stage, the disease was called chronic myelogenous rather than chronic myeloid leukemia, and the name sort of keeps on changing in different classification schemes. In any case, here is the normal chromosome 9 and chromosome 22, and in the 922 translocation, as we've now learned, there is a movement of a little bit of chromosome 9 to chromosome 22 and vice versa. So that's there a fusion of the BCR and Abelson1, ABL1 genes, with the major action occurring on the short chromosome 22, the BCR-ABL fusion. There's also a reciprocal Abelson BCR fusion on the long remnant arm of chromosome 9, which has attracted some interest over the years, but I think it's now recognized and appreciated. What we really care about is what's occurring on the short chromosome 22 with the BCR-ABL fusion. And this is perhaps what it looks like in cartoon form: BCR domains on the left, Abelson domains on the right. And I think what is underappreciated is that the breakpoint in the Abelson gene with the loss of the first exon leads to the loss of the normal 5' autoregulatory facet of the protein molecule. So it normally self-regulates, but as a consequence of this translocation, this 5' end or amino end of the protein molecule is locked off, and now it loses self-control. And as a consequence of that, a number of complicated, simplified here, downstream pathways are activated, resulting in increased cellular proliferation, decrease in apoptosis, with those two phenomena then accounting for the accumulation of the cells that we recognize in the peripheral blood. And we recognize them in the peripheral blood because they lose cellular adhesion, and so myelopoiesis spills over into the blood, accounting for the hematologic features of the disease. A fourth facet that is not illustrated on this cartoon that I added is the generation of reactive oxygen species by this BCR-ABL fusion. This leads to quite profound genomic instability. This accounts for the normal natural history progression of the disease, as well as the development of tyrosine kinase domain mutations that can make therapy a little bit more challenging. Progression of the disease is seen in virtually all, 100% of untreated patients go into accelerated phase or blast phase. However, with the introduction of tyrosine kinase inhibition, which has been so remarkable in controlling this disease, far fewer, 1 to 5%, will enter accelerator as blast phase. So I'm going to focus now a lot more on genetic testing in CML through the three important phases where it's important: at diagnosis, monitoring, and resistance. So with regard to diagnosis, if you encounter a peripheral blood smear with all the features that we've seen in the peripheral blood, you're likely to want to do cytogenetic studies. And if you do conventional banding studies, you're likely, depending on your denominator and morphologic astuteness, to find the 922 translocation for the dropped cell phone there in 95% of cases. And then boom, you have a diagnosis of CML. What about the roughly other 5% of cases in which you're not able to demonstrate by cytogenetics a fusion, a translocation rather, by chromosomal banding analysis? It's there that molecular genetics is required to demonstrate the BCR-ABL fusion. Here, for diagnostic purposes, you could use FISH or RT-PCR. And in roughly 1/2 of that 5%, 2.5%, you will show that there is indeed the translocation that happened to be cytogenetically cryptic. What about the other 2.5%? You cannot call those CML. We used to use the term pH-negative CML historically. That is no longer an acceptable diagnosis. These patients have alternative diagnoses that you have to search for, such as CMML or the unfortunately termed atypical CML. So if we're going to find the cytogenetic abnormality in 95% plus of cases, do we still need molecular testing? And the answer is yes. We still need to do FISH and/or RT-PCR to prove that there is a BCR-ABL fusion, which is the target of the targeted therapy. And also we need to know where the breakpoint is, particularly in the BCR gene, so we know which isoform to track for measurable residual disease. So if we're going to do a molecular testing in all cases, do we still need cytogenetics? And the answer there is yes as well. These are complementary technologies, and really patients should be afforded all three in an ideal circumstance to do cytogenetics, FISH, and RT-PCR. And the reason why we need to do cytogenetics, even if we've got a documented BCR-ABL fusion, is to look for so-called clonal evolution or additional chromosomal abnormalities, ACA, that can occur, of course, in pH-positive cells when the disease accelerates, as we'll talk about in a moment, but also can occur in pH-negative cells, cells that lack the BCR-ABL fusion, and that was seen in the early days of tyrosine kinase inhibitor therapy with imatinib. This was an interesting phenomenon seen in about 3 to 10% of patients, and it was a little bit intriguing as to what this was. Was this a reflection of CML hit actually occurring before BCR-ABL? Were the TKIs inducing a secondary neoplasm? I think these are still open questions, but we've also learned subsequently that depending on which specific ACA is found, it may have a bad, such as with monosomy 7, or complex abnormalities, or a neutral connotation with trisomy 8, for example. So disease has a capacity, as we've noted, to undergo metamorphosis into accelerated and blast phase. And this is a composite karyogram of the major additional cytogenetic abnormalities that may be harbingers of transformation and indeed can be used to
Sorry, Prof. Bag, I think you are muted. I don't know how that happened.
Sorry, I think when you muted everybody, you muted me as well.
Apologies.
That's okay. So I'm not sure how long I've been muted for, but I presume
About
not.
10 seconds.
Okay. So that would be 14 slides in 10 seconds. So cytogenetics I'm mentioning are additional abnormalities that may be seen at the time of disease progression are listed here. I got as far, I think, as talking about isochromosome 17q. And although we talk about isochromosome 17q and p53 is on the short arm, the p arm, this actually leads to p53 loss. And there are others as well. But of course, it's not only cytogenetics that can be used to identify disease progression. The ICC classification still retains increased blasts between 10 and 19% as being a marker of progression, together with a basophil count of greater than 20%. They've actually trimmed down the numbers from WHO 2016. There are other groups that have other criteria, so this is quite confusing. The European Leukemia Network, which has been adopted by most people around the world, requires 15% blasts to define acceleration, or the sum of blasts and promyelocytes to exceed 30% to define acceleration, or platelet count of less than 100 of therapy. The ICC and WHO classification schemes diverge here, with WHO actually completely eliminating accelerated phase and suggesting that CML is not a triphasic disease, but a biphasic disease. Nevertheless, ELN and the NCCN have retained recognition of the triphasic nature of the disease. Yet other criteria are found by the MD Anderson Cancer Center and the International Bone Marrow Transplant Registry. And so, as I've mentioned, the defining features of metamorphosis are a little bit confusing. When transformation does occur, this occurs to AML in about 2/3 of cases, ALL in about 1/3. Why? Because CML, of course, although we call it a myeloid neoplasm, originates, as we mentioned, in a true hematopoietic stem cell, and that accounts for its capacity to transform to ALL. And there's certain mutations that accompany these different flavors of transformation: ASXL1, RUNX1, BCORL1, typical of myeloid transformation, and Ikaros zinc finger or CDKN2A and B seen in a transformation to ALL. And these mutations, or the development of these mutations, are not currently considered criteria for progression, but that may change. So at presentation or after diagnosis, certain cytogenetic abnormalities can be used to diagnose disease acceleration. And here are the 6 major root cytogenetic abnormalities, which when present can be used purely on the basis of cytogenetics to designate disease progression to accelerated phase. And the rationale for WHO removing the accelerated phase designation is that these may not be associated nowadays with an adverse prognosis with the availability of tyrosine kinase inhibitors. And just importantly, also trisomy 8 is not considered particularly bad, the same as when we saw it with pH negative cells. During the course of the disease, there may be major root cytogenetic abnormalities. There may be minor root cytogenetic abnormalities that allow you to identify disease progression. The minor root abnormalities referring to everything other than the major root ones. Blast phase, as I mentioned, historically, before the advent of disease-modifying drugs such as tyrosine kinase inhibitors, was unavoidable, but currently mostly avoidable because these drugs have such a potent effect. And this is only seen in about 1 to 5% of patients nowadays, usually quite early on in therapy. And as I mentioned, this may be myeloblastic or lymphoblastic for the reasons mentioned. Let's pause for a moment to look at what's going on at the DNA level. That's important for molecular testing and RT-PCR. So this is a cartoon of the important BCR-ABL gene on chromosome 22, where most of the breakpoint heterogeneity occurs. This is a large gene with 23 exons designated by E. Historically, older terminology used B2 and B3 terminology, C3 and C4 terminology, which should be avoided. It can be confusing to use those terms. Most patients with CML will have their breakpoint in and around exons 13 and 14, so-called capital M or major breakpoint cluster region. Less commonly may occur after exon 1, lowercase m or minor breakpoint cluster region. And finally, the third region where their breaks may occur, there are others, is in the micro or mu breakpoint cluster region after exon 19. Virtually all CMLs have the breakpoint in the MBL, but not quite 100%. Roughly 98% do, 1% have minor breakpoints, 1% have micro breakpoints, plus or minus. Of course, the Philadelphia chromosome and the BCR-ABL fusion is quite common in a pH positive in adult acute lymphoblastic leukemia. Indeed, it's the most common translocation in adult acute lymphoblastic leukemia. But in general, in adults, the breakpoint tends to occur here in 60% of cases, but here in the CML, if you want to use that terminology, area in 40% of cases. Although pH positive ALL is less common in kids, many more have their breakpoint in the minor breakpoint cluster region. So depending where the breakpoint occurs, it may alert you to what you are dealing with. So if you have a patient with CML and a breakpoint in the M, capital M, major breakpoint cluster region after exons 13 and 14, the picture, hematologic picture then, is that of classical CML with granulocytes in all phases of maturation. But when you get the minor breakpoint region, there's a more likely manifestation with monocytosis, and this can mimic CMML, and that's certainly a diagnosis you don't want to make in a patient who is more likely to respond very substantially to tyrosine kinase inhibitor therapies, whereas that's not the case with CMML. So always an important consideration in a patient with monocytosis to rule out a minor breakpoint region positive chronic myeloid leukemia. Those in the micro breakpoint cluster region over here tend to manifest with just neutrophilia rather than the granulocytes in all phases of maturation. This was formerly known as chronic neutrophilic leukemia. That is no longer the case. There is some literature, but not very compelling, that the breakpoints in exons 1 and 19 give a worse flavor of disease than if the breakpoints are in the classical region. Yet there's other evidence that the exon 19 breakpoints are more indolent. So I don't think this affects therapy. There's also data to suggest that an E13 breakpoint is worse than an E14 breakpoint. That seems to be real, but also a bit controversial, maybe technical, yet other breakpoints can occur after exons 6 and 8, but these are rarely seen, but you have to be alerted to them. If a patient presents with acute lymphoblastic leukemia and you show that there is a 922 translocation, how do you know if you're dealing with a de novo Ph positive B-cell ALL or CML presenting in lymphoid blast phase? Well, certainly the location of the breakpoints provides some useful information, as I've mentioned. You could treat the ALL and it goes into remission, and you could see what remission looks like if the BCR-ABL is still retained or not. Certainly, FISH can be helpful at this stage, looking at patients in remission for their ALL. And so what I'm alluding to here at diagnosis, here is a B lymphoblast with the different probes here in green and red showing a BCR-ABL fusion. Here's another B-cell lymphoblast with the BCR-ABL fusion shown in yellow, the red and the green together. So how can you tell which patient is which, who is de novo Ph positive ALL, which is CML, by looking at the myeloid cells? And a good cytogeneticist with some morphologic background will be able to distinguish a blast with a round nucleus from a myeloid precursor with a more irregular nucleus. Here we can see that BCR-ABL are not fused, and over here in this myeloid cell, they are indeed fused. So this FISH analysis was thought to be useful to distinguish whether we were dealing with CML in blast phase versus de novo B-cell ALL. But as often the case in the area in which we work, things are not that simple, because it's now recognized that there are two flavors of Ph positive ALL, those with a lymphoid-only pathway and those with a multi-lineage pathway. And those with the multi-lineage de novo Ph positive ALL, you cannot use FISH to distinguish them from chronic phase, from CML presenting in a blast phase. There may be some clues, there may be different associated genomic abnormalities. If you can determine the cell of origin, pro-B versus pre-B, that can be helpful. More recently, it's been suggested by specifically looking at the different DNA breakpoints in the genes may help distinguish, but it can be challenging. Certainly, there are also mutations other than Abelson, which we'll get to shortly, that you can see in CML, ASXL1, Icarus zinc fingers, RUNX1, and DNA methyltransferase 3A, amongst others, can be seen at the time of diagnosis. And it's thought that the presence of these is associated with increased bad outcomes and increased risk of a blast phase. Set D1B and UBE2A are mutations that seem to be uniquely seen in CML blast phase. ASXL1 is interesting. We know it to be a CHIP mutation, but when you look at the cohort of patients with CML, they seem to be more common the younger you are. At least one study has shown this, others have not. So 10% of adults will have this ASXL1 mutation, yet a higher proportion of young adults will have this, suggesting we are not dealing with an age-related CHIP mutation. As I mentioned, these two mutations may be specific to CML blast phase, SETD1B and UBE21. So just to summarize what I've just said, you can see these additional mutations in chronic phase. You can also see a whole bunch and many more mutations, of course, in acute phase. ASXL1 by far the most common mutation in chronic phase. A number of other mutations in addition to all the chromosomal abnormalities seen in acute phase. Worth noting that if you find an Icarus zinc finger 1 mutation at the time of diagnosis, this predicts rapid progression to acute lymphoblastic leukemia blast phase. So these mutations at the time of acute phase and other chromosomal abnormalities found in virtually 100% of patients. They are not only found in acute phase, in that roughly 1 in 4 patients with chronic phase will have another mutation that is worth knowing about. Moving now to monitoring, then various modalities, as you know, to monitor response to treatment, looking at blood counts, looking at conventional cytogenetics, chromosomal banding analysis, FISH, RT-PCR, both quantitative and qualitative. If you're doing nested qualitative PCR, that can be a problem, although it's perhaps the most sensitive technology we can use. It really is to be avoided in a diagnostic laboratory because roughly 30% of the normal population have circulating cells that harbor the BCR-ABL fusion when you are testing at such very low levels, approximating 1 in a billion, 1 in 10 to the minus 8, as listed here. This also tells us biologically that perhaps the BCR-ABL gene is necessary but not sufficient in and of itself to cause CML, and it's not the monogenic neoplasm that we think it is. When you start treating a patient with CML, there are various definitions of response: hematologic, cytogenetic, and molecular, and you're familiar with these various numbers that need to be considered when you're seeing how patients are responding, initially hematologically, subsequently cytogenetically, but ultimately at the molecular level. If I could have the next slide, please. Next slide, please. Oh, sorry, here it is. So when you look at CML and the response, you want to go through these phases of complete hematologic remission, complete cytogenetic remission, major molecular response, and so-called complete molecular remission or undetectable transcripts. And if you accept that there are roughly 10 to the 12, so I think that's a trillion, depending which system you're using, 10 to the 12 cells, a kilogram of cells at diagnosis, when you're in hematologic remission, you still have tons and tons of cells. And in fact, the previously identified MMR, major molecular response, you can still have a substantial number of leukemic cells and apparently be in a good spot. And that's the major molecular response. It refers to a 3-log diminution, more recent terminologies, or ideal levels of response down to a 4.5 log. And so MMR is the terminology used historically, now better to refer to it as MR3, molecular response with a 3-log level of reduction. The terms complete molecular remission and undetectable transcript are terms to be avoided. Rather use an MR terminology and the sensitivity of your assay, so MR 4.5. If you prefer to use percentages rather than log reduction, here are the rough equivalents. And it's interesting to note, in the initial days of imatinib therapy, roughly 98% achieved hematologic remission, 85% complete hematologic remission, 75% MMR, and 10% initially so-called CMR. That 10% now, with more years to follow patients, has been seen in up to 30 to 40% of cases, and yet the overall survival approaches 95%. So how does this occur? Well, there are probably interesting immunologic breaks and checks that are occurring to keep the disease in control. With MR 3.0, the old MMR considered a safe harbor of the disease where you are likely to do well. But nowadays, if you can get as far as MR 4.5, you are considered to be functionally cured of the disease. And of course, importantly, your assay, quantitative RT-PCR assay, must be aligned, and I'm sure all laboratories do this now, to the international scale. But there's more to CML than MMR. There is EMR, there is DMR, and there is TFR, terms that are important to know about these days. EMR refers to early molecular response, a 1-log reduction at 3 months, a 2-log reduction at 6 months, or what some have termed a very early molecular response, in which you can halve the number of BCR-ABL transcripts in just 11 days if you're able to do that with some accuracy. All of these are now noted to be beneficial. DMR, as I alluded to in a previous slide, is currently defined as greater than a 4.5. Some people refer to it greater than a 4-log reduction. This is attained in about 30 to 40% of patients, seen with first and second generation TKIs. The latter seem to do it faster and deeper, and this is a gateway to TFR. The benefit of getting a DMR initially was thought to be controversial. I think nowadays it might be an achievable or a goal that one should at least aim to achieve. What is TFR? TFR is treatment-free remission, where patients can stop treatment. So after being in DMR for 2 years, you are allowed, according to some protocols, to stop therapy. And this can be sustained in about half of the 30 to 40% of patients, so about 15 to 20% overall. And if you have a short time and a longer time in DMR, you're likely to do better. And it's been shown that if you're in DMR for not 2 years, but more than 5 years, you've got a 80% or greater risk, likelihood of maintaining treatment-free remission. A paper that just came out within the last month suggests that good old-fashioned morphology predicts TFR. So what this group did, and I've got the citation down there, did digital analysis of bone marrows to look at the different cell types that we all know and love and identify, but they did this on an electronic artificial intelligence-based manner and segregated out the various cell types, again, that we as morphologists can easily recognize, and to see what their impact was and predictive value was for treatment-free remission. And this is a busy slide, but essentially, if you look at this Kaplan-Meier survival curve here, you can predict treatment-free remission according to these authors based simply on the ME ratio, if it's greater or less than 10.6. You can also predict the probability of sustained TFR on the percentage of neutrophils in the marrow, mature neutrophils greater or less than 44.9% neutrophils. And finally, by looking at the shape using image analysis, the elasticity of the metamyelocyte nuclei, if it was becoming more differentiated or not, could also predict the likelihood of treatment-free remission. So it'll be interesting to see how these work in sort of real-world clinical practice, if indeed applicable. The third facet I wanted to talk about with regard to molecular testing is, of course, resistance. So roughly 25% of patients, so a not insignificant minority, become resistant to disease. With regard to imatinib and other tyrosine kinase inhibitors, this may be primary or secondary, with a number of different mechanisms underlying the development of resistance. These can also be considered BCR-ABL dependent or BCR-ABL independent. The dependent ones, of course, are the tyrosine kinase domain mutations, the most common cause of resistance. There may be BCR-ABL amplification at the genomic level rather than the transcriptional level. There may be clonal evolution, as I've alluded to, in which the BCR-ABL pathway becomes less important than other pathways that are activated. And then finally, there may be some genomic and pharmacobioavailability issues that affect the ability of the drugs to work. And these are sort of summarized on this cartoon here. There may be binding of the drug, for example, to alpha-1 acid-glycoprotein, so it cannot get into the cell. It may be pumped out of the cell by MDR proteins, mutations of BCR-ABL, of course, activation of other downstream pathways, or amplification of BCR-ABL gene itself may all account for resistance. There are a multitude of tyrosine kinase domain mutations, difficult to keep one's head wrapped around. Over 100 have been described, some more important than others, occur in different regions of the gene, the P loop, the binding domain, the catalytic domain, the activation loop. But these 6 here highlighted in yellow account for about 2/3 of all mutations. This complicated table gives you a sense of the number of mutations described initially for the first generation tyrosine kinase inhibitor imatinib, and as one goes through to second and third generation tyrosine kinase inhibitors, you can see how there are fewer mutations being described, albeit in the somewhat older graphic shown here. Ponatinib and others, third generation tyrosine kinase inhibitors, thought to be or are in fact effective against the recalcitrant T351I mutation. So if you look at the second and third generation tyrosine kinase inhibitors as compared with the first, as I mentioned earlier, they do give faster and deeper responses with an improved attainment of complete cytogenetic remission, major molecular remission, and even deep molecular remission. But I think the data still holds that they do not affect outcomes and survival. So that needs to be considered, of course, with the side effects and mutational profile in choosing therapy. Since we're talking about therapy, which I'm not really authorized to do, there are, of course, a variety of newer agents around for treating CML. one of which is asciminib, which is worth talking about. It's unlike all other tyrosine kinase inhibitors. It's an allosteric inhibitor referred to as a STAMP. It specifically targets Abel myristoyl pocket. That's where you get the STAMP term from. And if you remember one of the early cartoons I showed you, where I showed the 5' region of BCR Abel is locked, sorry, of the Abelson, excuse me, of the Abelson gene is locked off when the translocation occurs, removing the autoinhibitory function. What this very clever molecule does is restores this lost autoinhibitory function. This drug was FDA approved in the United States about a year ago, and is showing promise for maybe becoming the treatment of choice in the future. Time will tell, but of course, it has its own wily ways of working and inducing resistance. There may be mutations in the pocket to which it binds. There are other breakpoints in the Abelson gene that are less common. If they're an A3 breakpoint, you can affect the activity of this drug, which can no longer bind to the protein moiety. With regard to methods of mutation testing, there are a number of methods that are out there, and I'm not going to bore you with them. They're with different sensitivities, specificities, and biases. And although, Sanger sequencing will miss small clones, it has been thought, at least until recently, that Sanger sequencing, with its relative insensitivity, analytic sensitivity of around 20%, was sufficient to pick up clones that were of substantial size. However, more recently, people have been looking at more sensitive technologies, and this seems to become the method of choice for detecting mutations, not fancy error-corrected sequencing or deep sequencing, just standard next-generation sequencing with a limit of detection 1 to 3% may be useful and clinically applicable at the time of diagnosis. It is particularly helpful for looking for so-called compound mutations occurring in cis, and also some of the other gene mutations that we talked about earlier, those affecting ASXL1 and others. There are, of course, a number of other technologies that are out there that may be better and supersede what we're doing currently. Time will tell. There is DNA PCR. The RT-PCR, of course, is performed on RNA, but if you look at the DNA, you can get a 1 to 2 log more sensitive. The problem in this is extraordinarily labor intensive. It requires the development of patient-specific primers. Digital droplet PCR, very simple technology, appears to be more sensitive and a more facile laboratory test for looking for measurable residual disease. There are flow-based assays. There's isothermal amplification, quantum dots, long-read sequencing, many companies developing alternative technology for tracking disease. You don't need to test for mutations every time you encounter your patient, of course, and there are specific times when you may want to look to see if there is a mutation present. So if there is treatment failure, which traditionally has been defined by failure to attain complete hematologic remission by 3 months, failure to attain a major cytogenetic response by 6 months, failure to attain a complete cytogenetic response by 12 months, more recently using quantitative RT-PCR, a BCR-ABL level of greater than 10% at 3 months, greater than 1% at 6 months, greater than 0.1%, equivalent to a 3-log reduction at 12 months, being triggers for testing for mutations. Of course, if a patient did initially respond and loses this response, so is there hematologic relapse? Is there cytogenetic relapse? Or are there increasing BCR-ABL levels on 2 or more occasions showing a greater than 1 log reduction? That's the time to look for mutations. And of course, anyone in accelerated or blast phase, much more likely to have a mutation and hence worth testing them. This is an old composite Kaplan-Meier curve. It's over a decade old, but I think it still is very instructive. And it shows the median survival of patients with CML based upon different therapeutic areas. So historically, before 1975, the median survival of CML was just under 3 years. So very bad disease, very poor prognosis, likely to transform in 100% of cases to a recalcitrant acute leukemia that is difficult to treat. In the early 1980s, late 1970s, along came hydroxyurea to treat CML. This caused resulted in a slight shift in survivals. Along came interferon in the late 1980s, and this resulted in a further slight shift in median survival. Allogeneic stem cell transplant in the late 90s to the 2000s, still used, of course, in certain circumstances, had a major shift in survival of patients. But after 2001 and the approval and utility of tyrosine kinase inhibitors, the median survival has not been reached. And patients with chronic phase CML, their survival approximates that of age-matched controls. But you need to have availability to the therapy. This was a publication less than a year ago in the prestigious journal of the New England Journal of Medicine that showed a patient presenting with hyperleukocytosis who was in the Sudan, unfortunately, when the diagnosis was made, and there was no availability of hydroxyurea or imatinib, and the patient demised very sadly to this disease that is so sensitive to this now cheap drug, died 5 days after admission. Of course, there are non-CML myeloproliferative neoplasms that may be in the differential diagnosis of CML. Of course, they're distinguished by the absence of BCR-ABL and differences in blood counts, but bone marrow histology can help as well. So it can be particularly challenging to distinguish in the cellular phase of pre-fibrotic primary myelofibrosis before there's increased fibrosis and ET. And it can mimic ET, but I think a close observation of the megakaryocytes in this disease, are they tightly clustered, are they loosely clustered, are they cloud-like, is something you would see in pre-fibrotic PMF and not seen in ET. By contrast, in ET, you're more likely to encounter the hypolobated or so-called staghorn nuclei that is characteristic of essential thrombocythemia, noting that a thrombocytosis is not uncommonly seen in the early prefibrotic cellular phase of PMF. So just a brief digression here to discuss different types of staghorns, and I sort of encourage audience participation if you want to unmute, although I think everybody's been muted, so I don't think this facet is going to work. But I've got a picture of different kind of staghorns or antelope that I've encountered over the years. This happened to be one in the Highlands of Scotland, where I was lucky to visit a number of years ago. This is actually a white-tailed deer that I took out of my window that I'm sitting at now during a recent winter. These deer frequently come through our garden in summer and winter. This was a sprung-horn deer, a picture of which I took in Wyoming. This is, of course, an antelope that's instantly recognizable to all of you, but when I show this to American audiences, I can usually catch them out. This is, of course, not a deer, but a moose seen in Canada a few years ago. And of course, this is a deer. I did not take this picture, but a colleague who was visiting Israel sent me this picture of an Israeli deer. And I show these things not just really as an interlude or to be silly or funny, but apparently they do show these pictures in the college exams nowadays. So if you're a registrar watching this presentation, please, I hope you paid attention, and this may improve your chances of passing your exams. So here's a case I wanted to share with you of a patient with CML in chronic phase who had the classical small hypolobated megakaryocytes, so-called dwarf megakaryocytes. The patient was treated with a tyrosine kinase inhibitor and went into morphologic remission, went into cytogenetic remission, went into molecular remission, but the platelet count crept up and up and up, despite the CML seeming to have disappeared. And when we repeated the bone marrow biopsy in this patient, they showed, rather than the hypolobated dwarf megakaryocytes, these much larger hypersegmented staghorn-like megakaryocytes. And this was an interesting case of coexistent BCR-ABL and JAK2 V617F, in which the CML dwarfs were converted to ET staghorns on imatinib therapy. It turns out this is a not uncommon phenomenon. If you have a JAK2 or CALR or MPL positive myeloproliferative neoplasm, pH negative, you have a greater than 100-fold increased risk as compared with the general population of developing CML, according to the study from 2022. And the onset of CML is typically quite abrupt. A more recent paper from July of this year looked at colony-forming units in these patients, showing that the BCR-ABL clone arose in the JAK2 positive clone. In other words, they said it always goes in that particular direction. There were no cases of MPN arising in CML. More recently, in fact, just last month, there was another publication from the Munich Myeloid Laboratory that showed, in contrast to the previous study, there's an equal likelihood of progressing from CML to MPN or MPN to CML. The important message, I think, if you have a patient with one of these diseases and it looks like they're responding, but then something funky happens with their counts that's unexpected, consider the possibility of a coexisting or emerging secondary or unrelated myeloproliferative neoplasm. Okay, so to summarize what we've covered thus far with regard to genetic testing in CML, in terms of diagnosis, you have to do conventional cytogenetics. There's no way around it. Yes, you can do it in peripheral blood, but you're likely to get a higher yield in the bone marrow. Why? Because there are more dividing cells. Peripheral blood FISH is really not an alternative to cytogenetics. You won't have an evaluation of whether there are the additional cytogenetic abnormalities. You need to document an RT-PCR by RT-PCR, the BCR-ABL fusion. Traditionally, this has been done by the qualitative assay, excuse me. You have to do the qualitative assay because you want to know where the breakpoint is so that you can appropriately track measurable residual disease with an appropriate assay. Most people historically have suggested that there's no need for the quantitative assay. More recently, others have suggested a quantitative assay at diagnosis may also be relevant so that you can track the patient's response to their own internal standard baseline rather than an international standard. NGS, currently not a standard of care, but may become so in chronic phase, certainly very helpful in blast phase when new mutations arise. But as we talked about earlier, there are many mutations that can be found in chronic phase that seem to be biologically relevant. And so perhaps in the future, we will be asked to do that in chronic phase as well. With regard to monitoring, cytogenetics is important. You want to be sure the patient goes into cytogenetic remission. FISH may be an alternative way for monitoring the disease. It's of course not ideal because it lacks the sensitivity of quantitative RT-PCR. But if you have one of those rare breakpoints that cannot be monitored using a standard RT-PCR, you have to try FISH. Or there's some laboratories that may design a bespoke RT-PCR for your patient. But of course, that's laborious and expensive. Quantitative RT-PCR, initially 3 monthly, then 6 monthly, and testing for resistance, not necessary at diagnosis, is current thinking, but if there's therapeutic failure, a loss of response, or development of accelerated blast phase, that's when testing should be done. So if we summarize in the context of hematopoiesis, normal hematopoiesis, what can go awry and what are the different chronic myeloid neoplasms we may encounter? So assuming there's a hit to the pluripotent stem cell and we have too many granulocytes in all phases of maturation, that's CML. If we have a hit that leads to too many red cells, that'll give you polycythemia vera. Too many platelets, essential thrombocythemia. Something that turns the megakaryocytes on to elaborate more growth factors for fibroblasts, that's what underlies primary myelofibrosis. Too many mast cells, systemic mastocytosis. Too many eosinophils, amongst others, will give you the mouthful of an entity of myeloid and lymphoid neoplasm with eosinophilia and tyrosine kinase gene fusions. BCR-ABL, we know, lies at the center of diagnosing chronic myeloid leukemia. JAK2 mutations, exon 14 or exon 12 mutations at the diagnosis of polycythemia vera. JAK2 mutations seen, albeit less frequently than in P. vera, in ET and PMF, roughly 60%, with CALR mutations in about 25%, MPL mutations in about 5 to 10% associated with ET and PMF. KIT mutations generally underlie systemic mastocytosis. There are 6 groups of genetic events that underlie the myeloid and lymphoid neoplasms with eosinophilia. There are other mutations or cytogenetic abnormalities that may be seen in chronic eosinophilic leukemia. Chronic neutrophilic leukemia, which can mimic CML with the E19 breakpoint, of course, is rather diagnosed and associated with CSF3R mutations. The mixed myeloproliferative neoplasms listed here, CMML associated with its own portfolio of mutations, TET2, ASXL1, and SRSF2 in most but not all cases, and these are certainly not required for diagnosis. They are very characteristic, as are PTPN11, RAS, NF1, and Sybil mutations in JMML, and an infrequent but fairly characteristic mutation in atypical CML is SETBP1, sometimes ethanolamine kinase mutations in a subset of mutations. If you have a mixture of, if we go back to the bottom left of the slide, with ring sideroblasts and thrombocytosis, of course, associated with a combination of a JAK2 related mutation and SF3B1. One final difference between ICC and WHO, 2022, the criteria for diagnosing CNL, the numeric criteria, what the white cell count should be, is 25 by WHO, and that doesn't change. But in ICC, if you have the CSF3R mutation, GCSF receptor mutation, a white cell count of greater than 13 is required. So for those of you who read the blurb that someone else wrote, I wanted to introduce you to Frida and Phoebe over here, who are quite interested in South African history, and I try and keep them up to date on the important history of South Africa. So here they are with a bedtime story. I was reading them. One of them's already fallen asleep. Difficult to keep their attention going for too long. This was about 10 seconds later. They were fast asleep. I certainly hope I haven't put you to sleep, and I'll be happy to take questions.
Thank you so much, Adam, for this absolutely brilliant state-of-the-art summary of the current situation and the history of CML. I see that we have a very wide audience here. We've got pathologists from the state and private sector. We've got clinicians, clinical hematologists from the state and private sector. And I'd like to open the floor now for questions. May anyone with a question please unmute yourself and go ahead with the question? Do we have any questions from our clinicians? I'm not sure how widely available the new agent is, the asciminib. I'm wondering what your vision is in terms of that graph and treatment-free remission for CML. I mean, this really has been a wonder story in terms of diagnosis and therapeutics. In the coming 10 years, things have moved so rapidly. Do you think that we would be entering a situation where there would be a drug like this new STAMP inhibitor, which could put patients very quickly into remission and potentially cure them in a sort of quicker fashion than we have at the moment?
Yeah, I mean, I think, as you know, I don't treat patients, but it's my sense that as wonderful as many of these drugs are, and as clever as the scientists who develop these drugs are, the cancer's cleverer than we are, and its desire to survive is profound. And whatever fantastic drug emerges, there seems to be wily ways for the development of resistance, and we're seeing that with asciminib as well. So I don't believe necessarily with current state of knowledge and approach to the disease that it's going to be curable in 100% of cases. And yet many patients continue to live relatively normal lives but not to understate the consequences or side effects of some of the therapy. So attainment of treatment-free remission, I think, will remain a goal. And hopefully with time, the number of patients entering treatment-free remission will continue to increase.
Great. I'm not seeing any more questions. I've just got a quick practical question from our sort of day-to-day NHLS experience. You mentioned, so when we're working up a patient for CML, we would always send cytogenetics and molecular testing, which we can usually get a result for quite quickly. Would you be adding upfront FISH in that situation, or would you only perform FISH if, for example, the results were negative? Do you think there's a place for always performing FISH in that scenario?
Yeah. I think fish, I mean, I think if you can do all three, that's ideal. I think each one has its advantages and limitations. So if you had to drop one, probably of fish and RT-PCR and chromosomal banding analysis, I think the one that could be dropped is fish, but that may annoy some of the physiologists in the audience because it's an important test that they do. I think there are also some data, and I can't cite their specifics to you right now, but sometimes fish can pick up variant translocations that may not necessarily be evident on either cytogenetics or RT-PCR. Some variant translocations that there are some data to suggest they're a prognostic value. So fish may give you added value in that regard. Of course, you can get a fish result on the same day in an ideal world, whereas RT-PCR may take a little longer, but I don't think there's ever a medical emergency need to get a result and treat the patient emergently. Or, if you have to give anatinib, that's fine while waiting for the result. So I don't know necessarily that the rapidity of doing a fish test is a value. There may be some value, I think, in finding some alternative variant translocations.
Yeah. Okay, great. Well, thank you. I think we all stunned into silence. This was really absolutely amazing. And we have your humor and general knowledge as well to add. We're not going to forget the different stag horns. And this will go onto the Blood SA website and I'm sure be used by many, many registrars and pathologists reviewing and scientists reviewing this this complex topic. Really, let me just you can see my video. I just really want to thank you because I can see there's a huge amount of effort and energy that's gone into this with an update of the really recent up-to-date knowledge. So thank you very, very much. Vernon says his microphone seems not to be working, which is a pity because I'm sure he would have, he just says, great presentation. Thank you for a wonderful lecture. Sorry, I am seeing a question here. We've got time for one more. Prof, what is your opinion regarding testing for P210 via qPCR diagnosis rather than doing RT-PCR qualitative at diagnosis, considering that most, sorry, just got to scroll down, that most patients would be P210 positive. If negative, then proceed with RT-PCR. I think sometimes it's just sometimes a pragmatic approach. Thanks for a wonderful lecture. That's from Caroline Stain. She's a clinical hematologist in Bloemfontein.
I think that's very much an appropriate approach since, 98% will have the breakpoint there. So it absolutely does make sense.
Okay, great. And then one last one, your thoughts on CD26 positive leukemic stem cells at diagnosis. That's not something that I'm aware of.
Yeah, so there's been emerging literature. I think it's probably just Vernon showing off how much
It
we
is
know.
Vernon.
Yeah, typical man. Yeah, I mean, CD26, just as an aside, from a heme path perspective, I think we came to learn about the utility of CD26 not in CML, but in the context of CTCL, cutaneous T-cell lymphomas, mycosis fungoides, are interesting. The way of diagnosing it by flow is that unlike normal T cells, CTCL cells, MF cells tend to lack CD26. What is CD26? See, I'm going off on a tangent here, but that's the risk you take when you're asking a question. CD26 is an interesting enzyme that's important in homing of lymphocytes to the skin. and CD26 loss functionally and diagnostically first came to our attention for CTCL. More recently, people have been looking at so-called CML stem cells and to try and distinguish CML stem cells from physiologic stem cells. And I think the reason for that, it's been known that even things like when you're in treatment-free remission with CML, the CML stem cell still exists and has not been eradicated or obliterated. And maybe it's the immune system that's holding it in check, and that's why patients survive. But maybe to your first question, Jessica, if there would be a way to identify and target the CML stem cell, that may be a way of approaching things in the future. And where does CD26 come in? To the best of my recollection, normal stem cells express CD26, whereas CML stem cells do not. I think there are a couple of other markers that can distinguish experimentally CML stem cells from physiologic hematopoietic stem cells. So that, again, I sort of should have known that to answer your question, but prompted by Vernon's question, that's something that may be relevant in the future. So thank you, Vernon. Good to see you and hear from you.
Wonderful.
Or not hear from you.
Wonderful. Well, it's my pleasure to close the meeting and to thank you very much again. And we look forward to hopefully seeing you soon again on this platform. Best wishes and thank you very, very much. And thank you to all the attendees for attending as well.
Thank you.
Great session. Thank you.
Thank you to Prof. Bag.
Thanks, Estelle.
Yes.
Bye-bye.